Welcome to the Shared Practices podcast. I am joined again by my co-host, Caitlin Embry. Caitlin, how's it going?
Doing really well this morning. How are you?
Good. It's so fun to be podcasting again after taking some well-deserved leave to be a new mom. And now baby's doing good, you're doing good, and we get to hang out again. So this is great.
Yes, it feels so good to be making content again and having these conversations on air. I feel like you stopped for 4 months, at least, I did. I know you didn't, but there's so many new relevant topics that we weren't talking about in the past and now have come to the forefront. So we have a lot to catch up on.
We do. And it still floors me that 9 years into podcasting about practice ownership, like our last call that we did, the calls I've been doing with George recently, we still have new stuff to talk about. Like I don't even understand, and it keeps getting better, and it keeps like it's just fun. It's crazy that this is what we get to do. So um, I've got a really specific scenario today that a friend came to me. He was looking at a chart acquisition several months ago, and in looking at it, I kind of looked at it with him and I was like, you know what? I think this could be really good. Um, I would pull the trigger on it. Like he had he's got five ops, room to expand to a sixth. He had 5 hygiene days. So about 1,000 active patients who are getting seen every 6 months, and had the opportunity to purchase 1,000 charts
Wow.
from a retiring dentist who couldn't sell his practice. He is less in network than the charts that he's buying, and so there's not going to be a complete conversion of patients coming in, with some of them not being on the same insurance. But I think the arrangements of it, and I feel like Suzanne and I, or George, and we've done an episode on chart mergers at some point
Okay.
on the acquisition side of it. And I like off the top of my head, I wouldn't be able to have a current intelligent conversation about even how to negotiate and the different structures,
Mhm.
all that. But I
I could
believe he
probably
did some.
touch on it a little bit.
Okay, well, I mean, I'll tell you what I think they did, which was he bought 200 charts outright for a fee, with the remainder coming in as patients come in, then they pay out for those charts. So there was a limited, like, here's some amount of money that we're going to pay for these charts, and then past that, it's kind of pay on performance on how many patients we're able to get in the door. With all that context, talk to me about what I just said, which was like the logistics and the acquisition, the buying, the negotiating of charts from what you've seen.
Yeah, from what and I think this is a two-part conversation. One is a chart acquisition right for me and my
Right.
practice, right? Just your own practice, and then let alone looking at the deal itself of what is on the
Right.
table for negotiations. And then also, how do we negotiate it? So I think a popular way to do it is paying X amount, like let's call it $125 per chart of patients that actually come in to your practice. And you value the value of those charts can kind of differ based on how long it's been since the patient has been in to see the last dentist, right? So if we're paying a lump sum of 125 per maybe patients that have been in the last 12 months, then maybe 12 to 18 months is worth less. That's kind of something that I've seen done. When I've heard George talk about this recently, though, he has spoken more about simply paying like 25 to 30% of production on those patients who actually came over to the practice. You pay X amount of production that was generated from those patients to that seller of the charts, and you cap it. So you cap it in a couple ways. Like you cap it for a time frame of this only goes for 18 to 24 months and then we're done. And you also potentially want to cap how much the total payout could ever be. Because if you do really, really well on this, George kind of talks about you want a cap in place to protect yourself, if it gets to be really high.
Yeah.
So there, I think what we're hearing is like there is no one right way to negotiate these, and but this is the number one question, you know.
Well, and they tend to be weird deals because they don't happen as much, and I don't
Right.
think brokers are as familiar with them. And a lot of times they don't want a broker involved. They're just like, meh, I can't sell my practice, or I don't
Mhm.
want to sell my practice. But I want something out of it. So I think the creativity here is higher. But what you just said, of what George said, this is our advantage of having seen how a lot of these things go down. And my limited perspective, I've not done a chart acquisition. That's why I was like, I
Mhm.
can't speak intelligently to this, even though we've podcasted about it in the past, because I just don't know how, I would do it today.
Mhm.
But George has already outlined it, so I would text George is what I would do. But was that at a pre-owner event, or was that at a growth event for owners that he was talking about that?
It was actually in our owner mastermind. We've
Mm,
started back up with our owner mastermind calls really strong. And so for those doctors that are a part of our coaching program, our mastermind program, George is doing 2 calls a month where it's kind of like Q&A, ask George. And so that's where that was covered.
what a great question.
Mhm.
So yeah, that's an example of, I would literally just text George, but
Yeah.
if you want access to George, then you can sign up for the mastermind. Um, so there's the structures of it. I think going back to the earlier question, even though, is very relevant, of should I?
Hmm.
Does it make sense for me? And I think the two things that come to mind for me are vision and capacity.
Right.
And is there anything else, that you would see or say or ask, as we lean into that?
I think vision and capacity are a good starting point. And I think the question you want to ask yourself, assuming that you've looked at the numbers and your patient base is not necessarily where you want it to be, right? I'm assuming you're doing this if you're not maxed out, but we shouldn't
Right.
assume, right? So if you're needing more patients to come into your practice in order for you to grow the way you need it to, and you have the capacity to welcome those patients, both from the physical component and the provider component. So you've got the ops and you've got the providers to see them. The question I always ask is, depending on how you structure this deal, how much are you going to spend all in, low end, high end, right? And would you achieve those results better or worse through marketing avenues?
And with that, this cost of customer acquisition, of your different channels, your average new patients, man, if you've got an amazing reputation, the demographics are really in your favor in your town, you're barely doing any marketing, and you're getting 40, 70, 90 new patients a month,
Mm-hmm.
you've got the growth. If you can just continue to capture and flywheel it, you might not really need a chart acquisition. And in fact, it might overrun you, because you
Mm-hmm.
can't keep up with that and get them in the door and take care of them in a timely way. And so that would be a good circumstance to be in, that would make less sense to do a chart acquisition. And then on the other side, can you fit these new patients in, and can you grow in time to fit these patients in? Can you hire a hygienist in time? Do you have the space, the operatories, the room? And do you realize, can you estimate, and this gets into our later conversation, how much you're going to need to grow, which is hard
Mm-hmm.
to know ahead of time. How many of these are going to convert over? How many
Right.
am I going to get in my clinic? So what else would you add to that analysis?
Well, it just makes me think of the concrete example that we opened up the episode with. And so, if I'm thinking about a practice that is a solo doctor with 5 operatories and 1,000 active patients as it stands right now, right off the bat, just with those numbers, I'm saying yes to this
Yeah.
because just the math makes sense to where ideally for a solo doc, I want to see 1,600 active patients around there, right? I want to get us to a place where we can have 8 hygiene days a week and they can be checking for 2 hygienists 4 days a week. And so at 1,000 active patients, you're maybe more looking at 5 to 6 hygiene days. And so this could be the boost you need for your practice to say, great, I'll go ahead and offer this hygienist the full time position, or I'll go and find extra days of hygiene to get to 8 days. And now we will have that capacity to be welcoming those new patients.
Well, and when we were talking with my friend, I was with some other shared practices clients, and they, like, Graham Beard was on there,
Uh
and
huh.
I can't remember if Jess Preet was in there. They were like, you need to hire two hygienists or two more hygiene days like yesterday, because to absorb this, if you're already full at
Mhm.
5 hygiene days,
Mhm.
don't have a lot of openings, how are you going to bring these patients
Yeah.
into your practice?
Yeah.
They're going to be bottlenecked. And so it went from, he was like, yeah, we'll see how it goes, to no, 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 no. You need two with plans for that third hygiene
Right.
day, because this could round you out, take you from 5 hygiene days, which, a reminder to my audience, or to the audience, our audience, they're not mine.
They are kind of yours though.
No. Um, the ratio is 200 patients per hygiene day. That's why, like, for
Right.
Caitlin and I, the math is just so
Yeah.
obvious. We're like, okay,
Yes,
five
and
hygiene
that's what
days.
we have to remember, like, especially at our events, we say the same thing, like, at the end of our events or at the end of these episodes, everyone is hopefully going, "Huh, that makes a lot of sense," but
Right.
it's not so obvious in the industry, you know?
It isn't. And this is like, this should be dental practice management 101. Like, day one, they should make everyone write the formula. One hygiene day equals 200 active patients. You should have to write that like 40 times
Mhm,
so you never forget that the rest of your career. Um, but so if he's got 5 hygiene days, about 1,000 active patients, he buys another 1,000 charts and can convert 600 of those
mhm,
into active patients. He needs 3 more hygiene days, and that rounds him out to 8. So
mhm.
it's kind of this nice little puzzle piece of like, why wouldn't we do this?
Right.
Perfect setup. Yeah.
Yeah, I think the biggest thing that I would wanna make sure if it was a client of mine asking, "Should I or shouldn't I?" and assuming all of the cards are in place and I'm seeing the math and I'm also not seeing marketing doing what it should be doing, and I'm like, "Ooh, this is the boost we need." I going back to negotiations, however you settle this, I would definitely make sure you're only paying for those who are actually coming in.
Yeah.
It would if it were me doing it.
Well, and this is just like when you do a normal acquisition, the report that the broker gives you, or that the practice management software gives you, of active quote unquote patients,
Yeah,
is often very inflated and not
right.
accurate at all.
Right.
So depending on how we're doing the math, and if you've gotten representation that has pushed back and said, no, actually, based on the number of hygiene checks in the last 18 months or the last 12 months, here's actually the active patient count that we're acquiring. That's where you want to like look at, do we have our ducks in a row on knowing what we're buying and being very clear on how we're paying for it. So you're absolutely correct in that, because you might be, if you're paying for 1,000 patients, realistically, it's going to be some percentage, especially with um, transitioning from maybe in-network patients to being out of network.
Mhm, the conversion will be harder.
It'll be harder, and depending on how far the drive is from one practice to the other,
Yep.
um, all these things come into play. So moving into the logistics of what to do after you acquire these charts, hiring and opening hygiene, number one, what would be the kind of training that you'd want to do with your team on the phones, on reaching
Mhm.
out to these patients? How would you absorb them in the best way
Yep.
possible?
I think of this as the same training I do when a client is gearing up to really invest a lot in marketing. So there's a few different ways where we're kind of doing this injection into the practice of hopefully very, very increasing the new patient flow month over month in the months to come is like if that's really what we're focused on. So that could be in the form of we just invested, we're spending 5% marketing. We're expecting those results over the next 3 months. Or it could be we just did this chart merger. We're expecting those results in the next 3 months. Things along those lines. We just went in network with Carrington through profitable PPOs. We're expecting those results in the next 3 months because we're going to, all these different scenarios where we are hoping that we're going to get this huge influx. And so that training is, to your point, on the phones, the new patient phone call, making sure that is in tip top shape, working with a coach to do that, listening to our podcast episodes on that from the archives, really making sure we're clear on how we greet those new patients over the phone and convert them into successful appointments of patients who actually come in. making sure the team is very knowledgeable on our our insurance in network, out of network, if we are out of network, how to have those conversations to still motivate the patient to come in and try us, and just to give a brief overview of that, that is, we don't directly participate with that insurance company, but we have a lot of patients who do come with that insurance company. We gladly file on your behalf. We will do a complimentary benefits analysis for you so that we can have an estimate for what your costs will be here in our practice. Making it clear we still serve you. We're not just giving you the invoice at the end and you're submitting to your insurance on your own, right?
Mm.
That type of training. And I think making sure your patient experience and processes from front to back are in tip top shape as well. This is a good time to practice that patient experience from when they walk in the door to being seated. What steps are we taking? What verbiage are we using once we get them in the chair in the back? How's our handoffs, right? Like all of it,
All
making
the things.
sure it smells how you want, it feels how you want, preparing for this influx.
Well, and it's those fundamentals, and there might even be, you're talking about expanding hygiene capacity. There might even need to be new hires in terms of dental assistants
Right, and
or
front office
front
team
office team
and
members. So planning for best case scenario of like maybe start
mhm,
interviewing, because it might take a couple months to interview and find someone of the right quality, and that
right.
could work out. Like you've got advance notice. It's pretty rare
Yes,
that you get to make a bigger leap in
right,
total patient numbers.
right.
Normally it's this like
Steady,
gradual.
that's exactly right. So preparing for 30 additional patients than we're used to, it sounds kind of intense, but and it makes me think of too just preparing your schedule
Yeah.
and saving room for these people. Like we want to be able to say when Dr. Johnson's patients call and say, "Yeah, I got this letter. You guys are potentially my new dentist." We want to have a spot for them and to honor their 6-month appointment if they're due. Like we don't want to say, "Great, we'd love to see you in 3 months." Like that's not starting things off on the right foot. We need to be able to see them very quickly so they don't go, "Well, forget it. I'll just go to a different dentist."
I'm
You
out of
know?
here. Yeah.
Yeah.
Well, the other thing with this too, here's the great part, Caitlin, that our listeners need to realize is, because I've been out of GP practice for so long, and I did full art stuff, and then stepped back and ran our shared practices group, and then stepped back from that. I'm trying to pick up some surgery days, by the way. If anyone's in Indianapolis, I'd love to do some extractions for you. But um, I get to ask dumb questions for the audience, or things that I've heard, and
Hmm.
I'm not even faking these, because I'm like, oh, is that allowed? Is that okay? So someone gave this dentist the advice of their policy. They are out of network, and so they have a lot of insurance driven patients who call or who are coming into their practice. And he said, what we tell our patients is, we guarantee you that your out of pocket on the first visit won't be any more than $50. Um, and the goal is to just get them in the door and get the, whatever benefits are available for out of network coverage. And then from that point forward, they'll kind of see and know. And that was his advice of,
Hmm.
here's what I would do. Is that allowed? Is that okay? Can we say that if we're out of network?
Yeah, I mean, if you're planning on honoring that, and so you'll submit to the insurance is going to come back and pay what they'll pay. And let's be clear, the first visit is preventative and diagnostic codes. It's not treatment,
Right.
right? But like, so we're
Right.
saying that that copay is going to be maxed at 50 for more of a routine visit as patients perceive it, right? Um, Yes, my initial answer is yes. If you want to get technical, you just have to be very careful with what you're billing on your claim form. You can't submit to insurance, more than you're actually intending on collecting from the patient. You can't make a habit of that where we bill to insurance, but we always write it off no matter what. You need to bill on your claim form what you intend to actually collect from a reimbursement perspective. So putting your standard fees on that claim form, you're saying to the insurance company, no matter what you pay me, patient will be responsible for the difference of that. So you don't want to make a habit of reducing that more than what you actually intend to collect from the patient.
Right. Well, and this comes back to these, like, what can be done versus what
Mhm.
should be done, and all
Mhm.
of those, and kind of those judgment calls that,
But that's a really good way to I think patients just are scared of the unknown, rightfully
right.
so, with their insurance. And so that's a good way to say, come try us out. we can guarantee you that it will. And maybe you're looking at your standard fees and you're looking at what you typically see for reimbursement, and maybe it's actually 75. So
Sure.
if you want to really play by the book, make sure you're quoting something a little bit higher just in case, right?
Well, and that was a nice kind of just like, hey, if you want to lower the pressure on all those
Hmm.
conversations, because if you're trying to do, I think the other thing was like the verification ahead of time and trying to let the patient know what's going to be owed. This just takes all that away of like,
Hmm.
let's just get you in the office, we'll get this first visit done, we'll figure out what your benefits are, and then
Right.
we'll go from there. So okay, cool. So I got Caitlin's pseudo blessing, so I can come back and report that that is an option. Here's what you got to watch out for.
Right. Right. Another aspect I'm thinking of now, I'm really going on this of what would
Yeah.
we really need to do. Of course, these patients are going to be more like new patients than existing patients, but so you have to decide with your team, are we doing 90 minutes? Are we doing 60 minutes? Because depending on the quality of the x rays at the last practice and how frequently were they updating those FMXs and things like that, are we treating them all like new patients? That kind of thing plays a role. And even if we decide, let's say we decide, let's do 60 minutes, they were just at that last office 4 months ago, 6 months ago, like we don't need to treat this quite like we would a brand new patient where it's been years. Plan on that exam still taking longer. Like you'll probably bill a comprehensive because it's the first time they're seeing and so it is a comp exam. And so really work on co-diagnosis with your hygiene team, having them tee you up so those can be slightly shorter exams, but still those aren't going to be as fast as the patients who've been with you for a long time. So be strategic with which days. If we're adding hygiene, we have this wide open new schedule. We can say, let's try to put Dr. Johnson's transfers on Tuesdays and Thursdays, and then let's try to make my restorative schedule on Tuesdays and Thursdays, you know rock appointments that are high value, but I can kind of step out and go and do these. Like, let's not jam pack me with fillings on those days. You can be really intentional so that you're not launching into chaos that way too.
Yeah, and with that as well, the expectation that like these patients are, they're kind of like when you acquire a practice and it's a different treatment philosophy. Oftentimes, a retiring doctor has a lot of watchodonistry going
Mhm.
on, watchodonics, and so there's a lot to be done. And having that conversation delicately without offending them and driving them off with the co-diagnosis and
Yeah.
helping them see the philosophy and how this is good for them to address these things rather than just waiting. That is something too, exactly what you're saying, setting your expectations for how much time are we going to need and how
Right.
much kind of delicate explaining
Yes.
is
And what
this going to
approach are
require.
we going to take? Because we know our standard of care, but we know that we need to handle this delicately. And so, agreeing with hygiene as well, if it's a case of undiagnosed perio, what are we going to do? Are we going to say, this is what we recommend and why? Or are we going to say, this is how it's looking today? I want to get you a treatment plan. Let's see you back in 3 months. And if it hasn't improved, this is what we're doing next. Hey, we can't speak to what Dr. Johnson and his team saw 6 months ago, but this is how things are presenting today. And then I think on the clinical, like restorative side, if you see something that piques your interest if this needs to get treated, but you don't want to make it seem like this was being neglected, you're the dentist, not me, Richard, but I'm kind of saying like, hey, this lower right tooth, was this something Dr. Johnson was watching for you in the past? And kind of say like, yeah, I think he was. And then that kind of opens it up to go, yeah, I think it's time at this point, right? But you're kind of trying to bridge that
Give
communication
them the benefit
gap.
of the doubt and not
Yes.
throw them under the bus and
Right.
all that. So if they haven't done an acquisition before, this might be some personal verbiage training that
Mm-hmm.
you need to do so that you're ready to kind of tiptoe and lead
Right.
into without burning the
Trust
bridge.
and
I mean, this is exciting. These opportunities are not super common, but if people are aware of them, to get an extra 600, 800, 1,000 charts that you have the potential of converting some amount of them is such a great way to grow a practice, especially if you buy that ADOP practice, you buy that multi-doctor practice, potentially size-wise, that is a solo practice, or a productive solo practice where there's just so much room to expand. This type of opportunity accelerates your journey so dramatically. And so this is something to keep in the back of your mind and network, and you figure out who your older docs are. But also sometimes there's health that turns, and different opportunities that you can provide a solution for another dentist who maybe can't sell their practice traditionally, but is looking for some way to liquidate that goodwill. And it's a great win-win. So it's a lot of fun.
Yeah, I think this was a intriguing episode, and I think we'll start to see more and more of this, and be able to speak to what deals have worked, and what our clients have kind of experienced on the other end. It'd be fun to have someone on who's gone through this as a part two.
It would be. And like, I've even heard of DSOs going under and stuff like that.
Mm,
So there might be like fire sale opportunities
right.
where, you can absorb a lot of patients. So lots of fun things to think about and try out here. So we should look for, ask Suzanne and ask around. If anyone has done a chart acquisition successfully, has a story to tell, reach out to Caitlin. Caitlin, how can they reach out to you?
Successfully or unsuccessfully, we want to hear it all, is what I would say. So, yeah, send me an email, Caitlin at sharedpractices.com. We'd love to hear from you, have you on the podcast, or if there's questions now that the chart acquisition is underway and we're preparing the team and we feel like coaching is needed, send me an email. We can get you set up. So, we'd love to talk to you.
Awesome. Caitlin, this was a blast. Thank you so much again. We will talk to you next time on the Shared Practices podcast.